Gastrointestinal Disorders. Understand and demonstrate the approach to a physical exam in the patient with abdominal pain. Well, the physical exam is the most important part, history and physical, right? We've talked about that over and over again. That's where you're going to get your, start to form your differential diagnosis and figure out what you need to do next. So they need a thorough physical exam. You need to palpate, you need to percuss, you need to attempt to determine organ size if you can feel them, and you need to make sure you get a thorough history. I know it doesn't say history, but history is really, really important. Understand differential diagnosis for chronic abdominal pain. So functional, IBS, constipation, celiac or food intolerance, problems with the microbiome, which I'm just fascinated by, and we're learning more and more about. Those are the major ones I can think of with chronic abdominal pain. I'm sure I'm missing some because it's getting late and I'm sleepy. But that is what I can think of. So food intolerance, microbiome problems, IBS, IBD, functional, constipation, GERD. All right, understand the differential diagnosis for intestinal blood loss. Okay, take a minute, make a differential diagnosis. Okay, infection, E. coli, Shigella, Salmonella, Clostridium C. diff, Clostridium difficile, hemorrhoid, polyp, foreign body, and then your ulcerative colitis, Crohn's. Recognize critical findings, red flags that differentiate from the different functional from pathological abdominal pain. Interfering with ability to function, and I don't mean ability to go to school, because some kids use abdominal pain as an excuse not to go to school, and an excuse and ability are not the same thing. So if it interferes with their ability to go to school but not their ability to go to the skating rink or cheerleading practice, then that doesn't count. But interferes with their ability to be happy and to have fun, then that's more of a problem. If they're losing weight, if they're having blood in the stool, if they have a tender abdominal exam, if they have abnormal laboratory studies, then those are red flags for me. Those are certainly more concerning. Understand the presentation and basis of therapy for inflammatory bowel disease. So these are going to be the kids that are going to present with the red flags. So they're going to have blood in the stool, they're going to have abnormal labs, low hemoglobin, elevated inflammatory markers, weight loss. They're going to be missing things that used to make them happy. They're going to be unable to go to school because of the diarrhea and the belly pain. Basis of therapy, we're going to try to get their microbiome healthy, which again is an emerging field that we're learning more and more about. And then we're going to get them on an autoimmune regimen, an immunomodulator of some kind, steroids. Those kids are also at high risk for infection, so we're going to start treating that. Whether they have a concomitant cryptosporidium infection or who knows what kind of infection, we're going to evaluate and treat for that. Differential diagnosis of constipation and possible underlying etiologies associated with constipation in children. So the most common cause of constipation is functional. So it hurts one time when they poop, so they start holding it, or they don't want to quit playing, so they start holding it, and then it hurts, and then they hold it some more. So stool holding due to pain, or because they don't want to stop playing to go poop. And then the stool backs up. Also, the American diet is not all that great to promote regular stooling. Also, alterations in our biome are being off track in our biome health really promotes constipation in our population. So those are the more benign things that we see. Now, possible underlying etiologies would be things like Hirschsprung's disease or cystic fibrosis. So it is important to make sure that we are aware when constipation becomes something other than normal. So if they didn't stool in the first 24 hours of life, we want to make sure that we are looking for other possible etiologies for their constipation. List the differential diagnosis of diarrhea, including different causes of infectious diarrhea. We talked about some of those just a minute ago. So, lots of different causes of infectious diarrhea. Remember that Yersinia pestis kind of imitates right lower quadrant pain like appendicitis. Toddlers' diarrhea, they drink too much juice and they end up with diarrhea. Lactose intolerance can cause diarrhea. If you've had bad diarrhea from the stomach virus for a couple of weeks and you try to drink milk, you can have a transient lactose intolerance just because you pooped out all your bacteria that break down milk. Lots of different causes for diarrhea. Food intolerances. Review the presentation of and risk factors for pelvic inflammatory disease in an adolescent. Well, remember we talked about adolescents' frontal lobes are not well myelinated and they don't make great decisions. Yeah, that's a risk factor for pelvic inflammatory disease. They participate in risk-taking behaviors, so we need to be aware of that. We need to be aware of their choices. We need to be open. We need to be honest. We need to ask, and we need to be prepared to treat appropriately and confidentially. Know the differential diagnosis for both non-bilious vomiting, such as gastroenteritis, pyloric stenosis, reflux, metabolic derangements, and increased intracranial pressure. And for bilious vomiting, like small bowel obstruction and volvulus in children of different ages. I like how it gave you all of that stuff on one sheet. So acute gastroenteritis is the tummy virus. You're going to have the pukes and the diarrheas. Going to be non-bilious. Lots of different viruses that cause that. If you've been on a cruise ship, it's going to be norovirus virus. Lots of different viruses. Your presentation for pyloric stenosis is going to be, that olive-shaped mass in the left upper quadrant. It's going to be a firstborn Caucasian male that's been projectile vomiting every feeding, seems hungry immediately after spitting up, is irritable. You see the peristaltic waves when he's spitting up. He's lost weight, and you get the ultrasound or the upper GI, and you see thickening of the pylorus. Those kids need to go for surgery for pyloromyotomy. Go back and review the metabolic derangements that you see with pyloric stenosis. Remember, they have a very specific pattern of electrolytes that I am certain you will be expected to know. Reflux. Remember, you've got reflux and reflux disease. Those are different things. Reflux are your happy spitters, and reflux disease are your grouchy spitters that don't gain great weight. Think about what you would do in those two situations. Metabolic derangements. Think about your differential diagnosis there. Increased intracranial pressure. Those are going to be your kids with the obstructed ventricles with hydrocephalus that puke. Because of that, they need to go get their shunt. Bilious vomiting, that's going to be some kind of obstruction in the bowel that's going to need to be surgically resolved typically. So there you have it. I believe that's all in our GI section.